This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
It is a pleasure to be here. The shoulder has a very complex and unique balance between instability, or too loose of a shoulder, and stiffness, being too tight. And the instability can develop in two main ways. It can be a traumatic injury, such as a dislocation after an injury, or it can be atraumatic. No specific injury occurred, but there's just a lot of slop, a lot of play in that ball and socket shoulder joint. On the converse, we can have stiffness, where there's not too much play. Now it's too stiff and we can't move the shoulder, and this will manifest as pain. Joints are meant to move fully. If you can't move a joint, no matter what joint it is, whether it's the elbow, finger, shoulder, what have you, if it's not moving, it hurts. Well, why such a difficult balance in the shoulder? And that's because of the most mobile joint in the body. If you look at the hip, the socket portion of our hips are very concave. It's like a deep bowl, which makes our hips very stable. Hip dislocations are very uncommon. But on the flip side, we can't move our hip in a lot of different planes. Our shoulder, we demand a lot more motion out of our shoulder than we do our hips in terms of degrees of freedom of motion, getting all around our space around us. So to do that, we have a very shallow cup, a very flat cup on that ball and socket. As you see in this circus performer, it can be very extreme, where this person's able to get his shoulder all the way behind his head. And this relationship is due to the shoulder anatomy. Here's looking at the shoulder from the front, and here's looking at the shoulder from the back, and these muscles are important as dynamic stabilizers, we call them. As they contract, they help guide the ball in the socket in a nice fashion as we move our arm around in space. And underneath those muscles is the ball and socket proper. And here's our ball, here's our socket. There's a couple of terms that I'd like us to be familiar with, so as we go through and talk about some of these things, you'll understand what I'm talking about, and that is that this term here is the humeral head, the head of the humerus, and the socket is called the glenoid. What supports this humeral head and the glenoid are two main structures. One of these is the capsule, and this is one of the important structures that we want to think about in instability, and the other is the labrum. If we take this ball and socket joint and we pull out the head of the humerus and we look directly in towards that socket, what we see is this kind of picture. We're looking right towards the socket. The socket itself is kind of a pear-shaped, if you will, and around that socket, this is fairly flat, you can see that a ball would fall right off of that socket, either the front or the back or below, if it weren't for all these structures around it. And I wouldn't concern ourselves so much with what the names of these structures are, but just that those structures are important to hold that ball in the socket. The first structure, in terms of the labrum and the capsule, is going to be the labrum. This is this thin rim around the glenoid itself, around the socket, and that's the labrum. The next part is the capsule itself, and this is this tissue here. And here we see that in the cadaveric specimen, where we have the labrum, the thick rim around the side, kind of like a bumper, helps hold that ball in place, and then the capsule attaches to that around the outside like that. So we talked about two ways that instability can develop, either through a trauma or atraumatic. If I have somebody that's fallen down onto their shoulder, such as here, then that can certainly pop the shoulder out of joint. Whereas if I have someone that has chronic type of laxity or looseness to the shoulder, that's usually in atraumatic fashion. And the classic in terms of the athletes is going to be the gymnasts, as you see here, and the swimmers and the throwing athletes. But this doesn't happen just in young athletes. This happens in all ages. The traumatic dislocation or shoulder instability creation is when this ball pops out of the socket. The humeral head jumps out of the glenoid. That can also lead to other problems such as nerve problems. When the ball pops out of the socket, it can stretch some of the nerves as they come out from our neck and come down the arm, and can lead to some funny nerve patterns after that ball pops out of the socket, as depicted here. The ball usually pops out anteriorly, and that would be in the front of the shoulder, so towards your chest. And that's just the most common type of dislocation, and it's usually out into this position. It's someone that falls, they're skiing or they're doing something, they fall onto their arm like this, and the ball pops forward on the shoulder out the socket. The exception to that is those rare cases where it pops out the back. And to pop out the back, the classic scenario is either a seizure. People with seizure disorders are familiar with this because they many times have multiple dislocations, and electrocution. And the reason for that is when you have a seizure or electrocution, you have a violent contraction of your musculature. Our strongest muscles are the ones that internally rotate and bring the arm towards our chest. So if I snap and internally rotate towards my chest, that's going to push my ball outside the back, outside posteriorly. And that's why those are the exceptions to the normal rule of it popping out the front. Well, what do we do? What do you do if it pops out of the joint? Well, you put it back in, and we give that a term of reduction. And this is depicted here, where through traction or pulling on the limb, we can put the ball back in the socket. And this may or may not require some sedation. All of those rotator cuff muscles you just heard about start to contract and spasm if your ball pops out of the socket, and that can make it very difficult to yank that shoulder back in place. You also want to think about checking x-rays to look for any broken chips off when it popped out, to look at the direction of the dislocation. Is it anterior or posterior? When do we put it back in? Well, if it's a situation where I see somebody that dislocates and I'm working the game or what have you, then I'll put it right back in on the field, because that's the best time. The muscle hasn't had time to spasm and get tight, and you can get it in right away. But in general, the usual scenario is the patient comes to the emergency room and we give them sedation and then pop it back into place. There are some people, about 10 to 20% of my patients with shoulder dislocations say, well, they were skiing and they fell and felt it pop out, and they were able to just maneuver it in such a way to put it back in place on their own. This is an example of a shoulder that's popped out anteriorly. Generally, you see a little divot between the top of the shoulder blade and the ball down here, and usually holding the arm down like this. Here's the ball in front of the socket on a dislocated shoulder, and here's, after it's put back in, you see the nice alignment here between the ball and the socket. Remember, the rotator cuff is on the top up over here, and here's our glenohumeral joint. This is an important x-ray that we always get on anybody that we're concerned about dislocations or instability. And this will be a recurring theme, and we look at some of the other imaging studies further in the talk. And this is called the axillary view. The axilla is our armpit, essentially. And by taking an x-ray right into our armpit, we get a nice view of the golf ball on the tee, if you will. And this is our golf ball here. Here's our tee. And this shows that the ball is resting nicely on the tee, and we don't see any pieces broken anywhere. This same type of view may be depicted in the MRI. Some physicians will choose to attain an MRI, magnetic resonance image, to get a better look at the soft tissues after a dislocation. Here's a normal shoulder where we see the ball on the socket, the ball on the tee, and here, this black dot there and that black dot there, those triangles are the bumpers. Those are the labrum that's helped holding in place. When someone dislocates, they'll push that labrum off. Here's that situation here, and you see this triangle has been pulled off because of the dislocation. In addition to pulling off that bumper of labrum, you can also pull off that capsule we looked at, and we see some of that stripped here. And also, once it pops off, it can actually impale some of the bone as it rides on the rim of that tee, as we see here. It can scallop off some of the bone. And that can make it even more difficult to keep things in place. And this concept is further depicted in this schematic, where here's our ball on the tee. The ball pops out of the socket. It pulls off that labrum, that bumper, which attaches to the capsule. And that can lead to this part right here impaling against the rim of the bone right there, and calling a Hill-Sachs lesion is the name we give to it, but it's basically an impression or a divot in the ball as a result of landing against the socket. Well, after we put it back in, we'll generally put the patient into a sling for a period of time. This is usually for a few days, but it can be a few weeks, but working on motion at that time. Will your shoulder pop out again if it popped out in the first place? And this will be more likely depending on your age. The younger you are, the more likely that the shoulder will pop out again. 90% recurrence rate if you're less than 20 years old, 60% if you're 20 to 40, and about 10% if you're over 40. If you're over 40, especially if you're over 60, and you have a shoulder dislocation, the most common problem is not it popping out again. The most common problem is an associated rotator cuff tear. So that's where we target our focus, is looking at the rotator cuff. Higher energy trauma will also affect this. In something like this, lots of weight, pushing the shoulder out of place, that's more likely to recur because there's going to be a lot of soft tissue damage in that situation. What can you do to decrease the risk of that ball popping out of the socket again? Well, you can get on a good exercise program with a therapist and work those rotator cuff muscles to help hold that ball in the socket. And you do that while you wait and hope that nature scars back in that labrum, that bumper, back to the bone. We're not able to predict who's going to scar back in and who won't, but it's always worth a try to let nature try to heal it up. What if the shoulder keeps popping out? Is there a time when you need to have this fixed? And this depends on a couple of factors. One is your patient lifestyle. If you're relying on essentially raising your arm up to the cupboard to grab the bowls, doing activities of daily living around the house, then most likely you would never want surgery for this type of thing because you're going to do just fine. However, if you're an active person, reaching back, basketball thrower, if you're an elite athlete with throwing, you're just not going to tolerate this ball popping out of the socket anymore. So the second issue is arthritis. With repetitive popping out of the socket, will this lead to arthritis in the joint? Well, we don't know the answer to that. I don't think that arthritis or prevention of arthritis is a reason to fix the labrum and capsule around a dislocating shoulder, because sometimes just fixing the shoulder itself changes the mechanics enough to lead to some arthritis. So our studies are still being done to see whether or not arthritis has an impact. And one other thing that can help us as physicians in terms of determining whether we would recommend surgery for someone is, how does the patient feel? Can I take their arm and bring it back in an anterior dislocator and put pressure of the ball against the rim of that socket and cause some discomfort, or so-called apprehension test, to see if that bothers them? And at the same manner, does that improve if I put pressure on the front part of their shoulder, or relocation test? The surgery for recurrent shoulder dislocations, like the rotator cuff, can be open or arthroscopic. The open surgery is the gold standard, and the recurrence rates are very low, usually 2 to 5%. What's done during this surgery is we take a little piece of that labrum that's ripped off, we make some drill holes in it, and attach it back down to the bone. And here's a step-by-step view of what we do, just like with the open procedures for the rotator cuff repair going through the deltoid. Well, the open procedure for the shoulder instability, we have to go through muscle. We're going through the front of the rotator cuff, the subscapularis muscle. We split that subscapularis muscle, and then we find the joint underneath. Once we find that joint, it's got our capsule and labrum present there. We elevate that capsule and then put some type of anchoring device into there and tether that back down to the bone through sutures. And often through a pants over vest type of closure, we'll tighten or imbricate this front of the joint so that it will not pop out again. And then lastly, we repair the subscapularis tendon, the rotator cuff muscle that we incised in order to get access to that joint. Well, the open surgery is very effective. 2 to 5% recurrence rate is pretty darn good for this complex problem. But arthroscopic surgery is a very appealing option for the same reasons as the rotator cuff. Traditionally, it was thought to have a higher recurrence rate in our literature. In the last 10 years, the recurrence rate been about 10 to 20%. However, this is changing, and it's changing because of the improvement in our techniques and our instruments available to us. The advantages, same as the rotator cuff, there's small incisions, about 1/4 inch. quicker recovery, and less muscle injury with decreased pain and decreased stiffness. Here we're depicting arthroscopy where we put the camera into the joint this time rather than up above to the rotator cuff. And we're able to look in the joint. Here's that view where we see the labrum, the rim around the bone here is the socket. And here's our labrum, and here's the surrounding capsule. And able to look at that. Through the arthroscope, coming through the skin, we're able to shuttle different cannulas into the skin. And through these cannulas, or tubes, I'm able to put instruments in and out of them to use these to sew materials up or pass suture. This is the general position that we have to place the arthroscope. Patients on their side, their legs are down here, chest is here, face is facing us, and this is the front of their shoulder, and this is about 7 pounds of traction that comes off the end of the arms. That's why it's usually done under general anesthetic. Very tough to do shoulder arthroscopy when a person's awake. We've done that with shoulder blocks and things, but it's difficult. More for the patient than for the surgeon. It's just uncomfortable to be on your side for that long. The Bankart lesion is the name we give to that tearing off of the bumper or the anterior labrum. And so here's our ball in the arthroscopic view. Here's our socket. The ball is trying to push off the front of it. This red part here is the capsule, and attached to the capsule, this white part's the labrum. And there's a defect right here. This is pulled off as a result of the dislocation. This is the same principles we use for any labral tear. In older people, it's usually not a fall and a dislocation. Older people, it's just repetitive activities. And many of you that may have had MRIs comes back as labral degeneration or labral tears. All of these same principles go. I'm talking about traumatic, but degenerative labral tears, we use the same principles here in terms of repair of them. We're able to put an instrument and wedge that in between the bone of the socket and the capsule to develop that plane. And then I put some type of rasp or file to roughen up the bone where I put in an anchor, and that anchor goes in to allow sutures to come out of it. Then I place some device that goes in and captures some of this tissue and helps pass suture through that tissue. If there's little anchors into here and here, I'm able to shuttle a limb of the suture off the end of that anchor through the tissue. And in that way, I can pull that tissue over to the bone where it's supposed to be. And that's the principle used for all labral tears again. This is an arthroscopic example here. We're looking at the socket here. That's the cartilage of the glenoid. This is the socket of the humeral head. It's nice and white. That's the way it should look. That's down in the armpit. This is just a bubble here. And as I come up, here's our biceps tendon up top. We're looking from the back of the shoulder to the front. This there is my probe, and I'm moving my probe down, and I'm feeling that labrum. Here's the labrum down here. This is in a swimmer here who had repetitive laxity, not so much trauma, but just kept partially popping out of socket. And as I lift the shoulder away, you can see the labrum. I'm lifting up on the labrum right in that position. And here's our capsule out into the front. This is the way we like to see cartilage. Nice and white, looks like a cue ball around the humeral head here. I'm passing the instrument now. I'm capturing some of that tissue. It's a lot like taking a piece of cloth and just sewing that over and imbricating it to make it more taut. After I capture that tissue, I can pass some type of wire loop or an instrument like a suture. I can go in and grasp that out. I pull it outside the patient's skin, and I shuttle some suture back through where I passed my probe through. I prefer tying knots. You get a tactile feedback on how tight to make them. This is from a few years ago, and I put this in to illustrate a point. You may hear about thermal tightening or heating up the capsule to allow it to shrink, and we can thermally heat the labrum as well as other tissues. Lasers were originally used for this purpose, and the idea is that the thermal energy through this radio frequency wand may have a more controllable depth of penetration and cause less damage around to the neighboring structures. The jury is still out on whether this is a useful technique. I do not use this anymore for the last 4 years or so because I think that there are some negatives to using the thermal, but some physicians use it usually as a supplement to normal knots. I wouldn't be concerned if your surgeon is using the thermal if they've had good experience with it, but myself, I like a reversible problem If I put sutures in and there's problems of over-tightening or not tight enough, I can reverse that. If I heat tissue, I'm changing the ultrastructure of that tissue, and I can't go in and reverse it if I don't like the way it comes out, if the patient doesn't like the way it comes out. That's my personal preference, but I wouldn't necessarily run if you hear the word thermal tightening. This is another patient, which this person had a traumatic dislocation. Here we're looking at the same thing. Here's the ball here. Here's the socket down here. We're looking from the back of the shoulder. I'm coming around the top. There's the labrum up on the top. I'm coming down. There's the labrum on the bottom. Now we're down into the armpit. This is the capsule on the undersurface, down towards the armpit. And this is one, remember we saw when the ball popped out of the socket, it took a divot out of the ball, and that's what that divot would look like. It took a big chunk out of the bone since it popped out. And you can imagine, if you rotate your arm, that chunk can catch on the side of the socket. And if it does so, then that will cause pain and problems. So in this situation, rather than just grab the capsule, I'm going to put in some suture anchors. There's my probe here. There's not a great labrum here. It's all been stripped off. I burr up the bone, the sides of that bone, to develop a bleeding bed to allow to place the sutures. And once I do that, then it's ready for me to put in my anchors and pass my sutures. Here I'm showing them filing it as well to roughen up that area. Here I'm passing some of the suture through that inferior capsule out to the front of the shoulder. There's all different devices that will do this. Once that's passed through, I can reach in and grab the end of that suture, just like in the previous arthroscopy, and pull that out, another little 1/4-inch incision in the shoulder. Here I'm grabbing that loop of suture. Here's my anchor with my 2 limbs of suture coming out of it. I loop it through there, and I just pull it out. So now I've got a limb of that suture that's passed through the tissue that I pierced. Once I pull on those, you'll see it actually pull the capsule and tissue out towards your socket. There it's being pulled through, and there it's pulling up. And now it gets even harder to see the front of the capsule, and that's what we want. It shouldn't be that easy to see the front of the joint like that. That's because it's been loose. And there it's pulling on there to see that. And then I can tie the knots and secure that in. And here's tying the knot. After this type of surgery, generally use a sling for 2 to 6 weeks. Start elbow and wrist range of motion. Any shoulder surgery, the elbow gets very uncomfortable. The shoulder does not like being in a sling for a long period of time. So we start moving the elbow right away and start using grip strengthening right away. We do range of motion exercises for the first 6 weeks and then start strengthening. And then return to sport depends on what you do. If it's an overhead sport like tennis, 3 months. If it's a contact sport, it can be 6 months. So here's our segue to the next part of the talk, which is shoulder stiffness or frozen shoulder. One problem with this type of surgery is recurrent dislocation or recurrent instability. And again, I think the gap between the open and arthroscopic technique has been narrowed. We've been very happy with our results here in terms of an arthroscopic technique to repair the dislocating or unstable shoulder. However, stiffness is a worse problem than a recurrent dislocation. But prior to the surgery, you're able to come all the way out to here, and after the surgery, you're only coming to here, that's misery. You're not able to come out and do any of your activities of daily living. It causes pain. You're not moving the joint in a regular position. So now we look at the other side of our spectrum and that balance between the loose and the tight shoulder, the frozen shoulder. Frozen shoulder has also been called adhesive capsulitis. Adhesive capsulitis, capsule is the tissue we just learned about that surrounds our joints. Itis is inflammation of that tissue. Adhesive, it's like it's glued down. There's an adhesive around the capsule, it cements down and gets inflamed and eventually frozen. This can occur in about 2 to 5% of the population. More common in females than males, about 70 to 30%. And it occurs most commonly in the 40 to 70-year-old age range. We don't know what causes this. We have a lot of theories. We do know some risk factors or associations. The most common one that we see it with is diabetes. It can be either non-insulin dependent diabetes or insulin dependent. And in 10 to 20% of folks with diabetes, they will experience frozen shoulder. Other associations, thyroid disease and cardiac disease. Post-operative stiffness can occur as well as post-immobilization. That's one of the reasons we try to get people out of these slings as soon as it's safe. And that comes to what can we do to prevent this? Well, we can't prevent it really in diabetics. We don't know how to prevent it for idiopathic or unknown cause frozen shoulder, but in person that's after mobilization, we want to get them out of that sling right away. Frozen shoulder symptoms are generally a dull or aching pain. It's worse with motion, and you have stiffness. And when you have a rotator cuff tear, sometimes you're not able to lift your arm all the way up. But if it's a rotator cuff tear alone that's not a frozen shoulder, then the physician or the therapist or you will be able to take the arm and bring it all the way up, such as is depicted here, with full passive motion. And it's very important that we as physicians, we differentiate whether you are going through a limitation in active or passive motion or both. Active motion, how high can you lift your arm? Passive motion, how high can somebody else lift your arm? In a frozen shoulder, you have limitations in both of those motions. In a rotator cuff tear, you may have limitations in active only. Generally, there's three stages: freezing, frozen, and thawing. It starts out with the freezing, and freezing you think of, that's the pain. It just starts hurting. It starts off having some ache. If you start that, get it moving. And what happens is people go into slings, go into sling for 6 weeks, and then it's just even worse. Get it moving right away. After that, the frozen period can occur when the pain starts to improve, but now we have more stiffness. And then thawing, in which motion slowly returns to normal. Well, that's all well and good, except look at the times. 6 weeks to 9 months. You're going to be in pain for 9 months before we know what's going on, then it starts to freeze up. 6 months of a frozen stage, and then 26 months of the thawing. Are you kidding me? Who wants to go through that? That's a long time, and that's the problem with this, is that it will usually get better on its own, but it takes forever. And so what can we do to decrease this time that it takes for a frozen shoulder to thaw? Well, first we want to rule out any other shoulder injuries. This can be associated with a rotator cuff tear. It can be associated with labral tears or labral degeneration or fraying of the labrum. The other thing is we want to do pain control. The less pain you have, the more likely you'll be able to move your shoulder. And so this can involve the common anti-inflammatory medicines. Injections such as cortisone can be utilized. And this passive range of motion with a therapist is important. Here's some exercises that many people can do on their own. The standard exercises, the pendulum exercises, where you're leaning over and swirling your arm around in different circles, crawling the arm up the table. These are the basic exercises at the beginning, and then once you're able to get a little bit more motion, then we can move towards active assisted motion, as well as passive motion with pendulums, where you're using that pendulum to help pull your arm up that's frozen. Then eventually using a broomstick or a pole, where you're using that both for lying down and bringing the arm back, as well as using it to bring the arm out to the side and to bring the arm up forward. So you're assisting that poor arm to get up to where it needs to be. Your physician may recommend a nerve block, and the nerve blocks can help decrease the pain. Often in that freezing phase, it's very difficult. Many people don't tolerate therapy. So therapy makes it feel worse, and that's because of the pain. And so nerve blocks, blocking the suprascapular nerve, which is one of the main nerves around the shoulder joint, can help decrease the pain and allow a little bit more aggressive therapy. Surgery is needed in less than 10% of the patients that I see. Be very wary if your shoulder has just frozen and someone offers you surgery or wants to manipulate it or get it moving. You want to give it tincture of time. Those that have tried therapy for at least 3 months may be a candidate for surgery, but usually, in my practice, it's a 6-month rule unless there's some anomaly where there's just enormous amounts of pain, and often a year prior to doing any surgery. What kind of surgery is available? Well, there's manipulation, and that's a way of talking about gently forcing the arm into different positions, and basically you're breaking up or stretching that capsule around the ball and socket. This has to be done carefully with someone who's experienced, because certainly with the amount of torque you can put on the shoulder, you can break the bone by trying to do that. The next is arthroscopic release. By putting that scope in, we can shave up the capsule. We saw from those videos, you get a nice view of the capsule. Can't we just cut that capsule and make it move? Well, we can do that in the operating room. Often we'll do a combination of these two with both manipulation and arthroscopic release. But if your body is still in that freezing phase where things are angry, it will just go right back to the way it was before the surgery, even with aggressive therapy, and it's frustrating for the patient and the surgeon. Physical therapy is crucial. Timing of surgery is crucial when you get to the point where some of the pain is decreased and it's mainly stiffness. Brachial plexus catheters or blocks I commonly use here. We have a good team from our anesthesia group that can help put in a catheter or a block to decrease the pain so that in the recovery room and the next day we can work on still moving it and keeping things going. Recovery is varied. If you work at desk work, you may be able to go back the next day, not moving the shoulder. But obviously, manual labor, it can be months before you're ready to go back. And the last slide here is, what's the future of this frozen shoulder? Well, first of all, we're trying to figure out the cause. If we can figure out the cause, we can figure out how better to treat this. A lot of research is being done in that. Next is, we're looking at ways to try to selectively loosen up parts of that capsule without damaging the good tissue. This disease process is very similar to something that we see in the hand called Dupuytren's disease that some of you may be familiar with. That's a contracture of some of the fascia or tissue underneath your palm in which things, for no good reason, just start contracting up and causing a flexion deformity of your finger. Well, we've been trying injections for these Dupuytren's nodules to try to get them to break open, collagenase or some other type of enzyme that tries to break up the collagen fibers, the ultrastructure of our capsule. And this is a particular interest that we're starting to look at, where can we do this for the shoulder? Wouldn't it be nice if our shoulder gets frozen and we're able to inject the capsule not with cortisone, which is kind of this blanket anti-inflammatory and just hoping, but with something more selective that can help break up that scar tissue and not allow it to reseal back up. And I think that's going to be the future as we continue studies in that direction. Thanks for your attention, and we'll do a little question and answer section at this time. Pushing right here, if you have pain right here, it's the biceps until proven otherwise. And it's often a confusing problem because our bicep's down here, but the bicep muscle is down here. The bicep tendon crosses the shoulder and comes right into the top of that socket. And it's basically, we think of it as the appendix of the shoulder. We really don't need our bicep to cross the shoulder. That doesn't improve our strength. The classic example is John Elway, who had horrible biceps pain, and it finally ruptured, and after it ruptured, he won 2 Super Bowls. And he said, in Sports Illustrated, he's quoted as saying, "I wish those darn doctors would have cut that thing years ago." And we don't need our biceps to cross the shoulder joint. You have full strength without it crossing the shoulder as long as it's up near there. And so that's the biceps can be a major pain generator. It doesn't mean you have to cut it. It just means that there's ways to treat that biceps when you have pain right in the front of that shoulder like that. It can also be some other things such as the front of the rotator cuff and other problems. But where you're pointing, that's biceps until proven otherwise. Biceps problems are treated through a similar algorithm of the therapy and the rest, relative rest. Biceps injections can be helpful by it's a little bit harder. You get a small little sheath, a thin little tendon, like a straw size that you're trying to put the needle in, but it can be helpful. But it usually responds to rest and anti-inflammatory medicines and sometimes injections. Some people come to the need for surgery for that, and we get a great look arthroscopically at the biceps tendon and can often shave it up, smooth it out, if you're not one of the fortunate few that nature is able to heal it up on its own. The question was, can I comment on joint replacement? Joint replacement is basically putting a prosthesis in to the ball and socket portion, the humeral head and the glenoid. And the prosthesis is similar in construct to the types that are being used for hip. In terms of recreating in the hip would be both the hip, the head of the hip, and the socket of the hip. In the shoulder, one thing I do want to clarify for his rotator cuff is that it's not a separate issue. If you have advanced rotator cuff disease and tear, the natural progression is arthritis. If you don't have a good rotator cuff, the humeral head will rise up in many cases and start banging up against the socket and cause arthritis and progressive pain. this type of wear and tear can also cause arthritis. Arthritis being wearing down of that nice smooth cartilage that we saw in those videos. If that occurs and shaving it up and smoothing it out doesn't take away enough of the pain, then joint replacement is an option. Joint replacement is a surgery that I do. Joint replacement is a surgery that has not had the results that total hip replacement has long term. There's a number of reasons for that. One is what we talked about. You've got a very shallow cup. It's a sloppy joint. How do we get a big piece of metal on plastic to hold in nicely? Especially in someone, and in many times this is the case, someone who doesn't have a good rotator cuff to help balance the joint as you move it. I think it's a great procedure for people that have horrible debilitating pain of their ball and socket. Understanding that it does not give you this in most cases. It will give you, my expectation after a joint replacement in the shoulder is to be able to get the arm up to 90 degrees, parallel with the floor, hand to the mouth and hand to the back of the head. So I have patients that come in and say, well, why would I want that? I can bring my arm all the way up above my head. Well, they're not candidates in my mind for shoulder replacement. They're doing too well for it. I have patients that come in, any little movement, and it's killing them. And they may be able to get to here, but it's just a struggle. And so in those folks, they're good candidates for joint replacement. The same risks as apply to the hip and knee apply to the shoulder, the risk of infection, the risk of loosening. The biggest problem we have with the shoulder is not so much of the ball loosening, it's the socket. Because of that shallow dish, how do we get something to really stick on that socket so that when you're using your arm for everything we do, even if we're not walking on our hands, you're still constantly using it and putting loads against that socket, and it can lead to some loosening. So the results haven't been as good as long-term as the hip, but I think it's very good in select cases. What are the anti-inflammatory medicines available, and what do we recommend? And I get that asked every day in clinic. And essentially, the anti-inflammatories, you hear the term NSAIDs. NSAIDs is an acronym for a non-steroidal anti-inflammatory drug. Well, the steroid drugs, we know what steroids are. These aren't the steroids the anabolic steroids that's in the newspapers all the time. These are catabolic steroids, ones that actually decrease inflammation and break down tissue, like cortisone shots. Well, there's medicines that are non-steroidal anti-inflammatories, and the classic one is the Advil, the Naprosyn, now Aleve over the counter, indomethacin, Motrin. All of those are the first generation of anti-inflammatory non-steroidals. The second group is the second generation called COX-2 inhibitors. COX-2 is basically just the enzymatic pathway that we look at. And so it works a little bit differently, but you may have heard the term COX-2 inhibitor. All that means is it doesn't tend to affect the gut as much as the traditional non-steroidal anti-inflammatories do. So a whole new line of medicines has been looked at in terms of the COX-2 inhibitors. This is the Celebrex, this is the Vioxx, this is the Bextra, among others. These are great medicines. They tend to not irritate the gut lining as much as the others. They don't work any better than the Advil. In fact, none of these work any better than the aspirin. In some people, one will work better than the other, and that's why many people come in and say, I need my Naprosyn. It's the only one that works for me. We don't know why that is, but I know that they all work just a little bit differently, and one may work better for you. So try out some of the different ones. The whole Vioxx issue that's been in the newspapers lately is very interesting, because I think that's a big scare based on one study where it's been taken off the market, where it really may be a good medicine that may be back on soon and back in use commonly. And I give the example, one of my patients is the chairman of our cardiology group here, obviously does a lot of heart attack and stroke care, which was the adverse effect seen with the Vioxx. And he has a stash of Vioxx at home and doesn't want anyone to touch it because he loves it and he takes it every day. So if the chairman of cardiology can handle that, then it gives, but you know, looking at the studies, the study has some flaws. I think it's the wise thing to do. It was a big study. You can't just say that study doesn't mean anything, let's keep it on the market. But I tell most people that it's fairly safe in someone that doesn't have a cardiac or stroke history. Obviously, I'm not going to prescribe it. But Celebrex, they're starting to do studies on that. We may find the same thing with Celebrex. We may not be able to get Celebrex much longer. Same with Bextra. If you've got cardiac condition or history of stroke, try out the other ones first, and you don't have any problems with peptic ulcer disease or reflux, try the traditional ones, the Advil, the naproxens first. Just avoid the whole mess until we figure that out. But having said that, I think the Vioxx is a lot safer than is thought to be right now. Great question. Do we have a lot of physical therapy after shoulder replacement? And I know there's some therapists in the room that I recognize. I use therapy in select cases. It depends on the patient and it depends on the therapist. I think that therapy is a good thing across the board, but I get very nervous on shoulder replacement surgeries using a therapist that I don't know and with a patient that may not be as committed and maybe a little bit more aggressive. For example, I had a patient that just had horrible arthritis who was fairly young for shoulder replacements, young being he's 50. That's young for a shoulder replacement. And he is a bounty hunter, burly guy, Marine, ex-Marine, that wants to lift weights and do everything. I read him the riot act. You cannot do all these things afterwards. After I did his pain was gone. He wants aggressive therapy and to be able to go and do military press again. And so no, someone like that, I just don't want to do it. But in a person that is afterwards having some pain and spasm, and I want to strengthen the surrounding deltoid, I want to strengthen the rotator cuff, and to get them for the activities of daily living, hand to mouth, hand to the back of the head, then yes, I think it's good. My concern is that success to a therapist in many cases, and again, therapists who are experienced with shoulder replacements know that this doesn't apply, but success to therapists that aren't familiar with shoulder replacements is getting all of your motion. Why can't you get your arm all the way over your head? And I get very concerned if they're getting to here without pain, doing everything they want to do, and we try to crank them all the way up straight. And I've seen real bad problems from trying to do that. If you have an adverse reaction to Celebrex, does that rule out the use of any of the other COX-2 inhibitors? It depends on the adverse effect. If you have itching or something like that, then we'll often try it if it's a relatively benign adverse effect. If you have a true allergy, breakout in hives, and problems like that that's a little more drastic, I just stray away from it. If you have an adverse effect serious, such as stroke or cardiac issues, absolutely not. Just avoid the COX-2 inhibitors until further studies are done. It's fairly easy to find out information about your surgeon, but how can you find out information about your therapist? It's easy to find information about me? It is more difficult to find out information about your therapist, but I think that comes down to trusting your physician and having your physician have experience in the procedures that they do, and being able to refer you to a therapist that's knowledgeable in that. I think that for right now, the referral process is the best way to go in terms of that trust, someone that's experienced with doing the shoulders. And you can ask the same types of questions. How many types of patients do they see? That I get asked all the time. How many of these do I do a month? How many do I do a year? How long have I been in practice? All of those things are reasonable questions to ask your therapist. If your therapist is locked into certain, in an HMO situation, it's going to be different. You're right. I have the luxury of kind of choosing whatever therapist I want to use here. And I also don't mean that, that you need a surgeon that does hundreds of these. No one does hundreds of shoulder replacements. They're just not as common as hips and knees. Our hips and knee surgeons here do hundreds. You're just not going to find a surgeon that does hundreds. You want some, in fact, the mean number of shoulder replacements that you do, I did a study on this a few years ago, across the country here, for people that do them, is 2 a year. Now, I do more than that, but that's just how uncommon the shoulder replacement is, and that's one of the reasons it hasn't advanced as much as the hips and knees. We just don't have the numbers to know. Is there a remedy for a stretched elbow secondary to shoulder injuries? And I had a patient like that today. I think that anytime you injure the shoulder, it upsets the balance of the overall limb. And as my specialty as upper extremity surgeon, I see a lot of hand and wrist problems. I see a lot of elbow problems as well as shoulder. Even if you didn't fall on your elbow, just by changing your mechanism of motion about the shoulder, you're going to compensate and potentially use certain muscle groups more than you would have. One I see a lot is tennis elbow or lateral epicondylitis after a shoulder injury. I'm not able to bring my shoulder up as much as I used to Therefore, I'm going to use my wrist extensors a lot more to lift things. And as I lift things, I'm going to bring my arm out a little bit so all of my load is coming from here rather than here. And so they'll come in and say, well, the rehab helped my shoulder, but now my elbow kills me. And so then we go that route. But absolutely, it's linked, and it's very common. What's the difference between the therapy between the issues I presented here and the rotator cuff, and how soon do we need to start them? And there was some confusion about the impingement starting therapy right away, but rotator cuff surgery waiting. I think that that's an excellent question, and I have, when I got done, I've been here for 5 years, and when I got done, I looked at all these different rehab protocols, and it varies quite a bit in terms of how quickly to move things. We know you don't want to keep it immobilized for a long period of time, but can we start the next day? Can we start the next week, or when? And I found what I thought was a reasonable alternative and have been using that, and I've modified it a little bit, but I have a set protocol that every postoperative patient has a sheet, depending on what I did, for when they start the rehab. In general, I have the patients starting that night, if it's an early morning surgery or if it's later in the day that next morning, starting right away on pendulum exercises, elbow flexion extension, and grip. I don't know of any surgery that we do, short of rare repairs where we have to hold people out like this, where you're ever going to injure the shoulder or ruin the surgery by starting right away with pendulum exercises, even massive rotator cuff repairs. Okay. Now, if you have to pull a tendon, a rotator cuff, so hard and tack it down that you need to hold them out like this, and if they come down here, it's going to pop apart, that's probably a tendon that shouldn't have been repaired because it's going to fail regardless. So pendulum exercises is something I use initially. If it's a big rotator cuff tear, though, then I may use a sling for 4 weeks and keep them out here. They'll come over and they'll do some of the pendulums, but they'll go right back in that sling, and I'm not going to have them coming across and moving it to protect that repair. Impingement, on the other hand, that subacromial decompression or shaving some of the bone, you can't undo the surgery by using it, so we'll start right away with whatever they want. Could a patient after impingement start right away with crawling up the wall? Yes, but that's not wise. That's going to just cause more inflammation and actually delay their recovery. So the answer is you could start therapy right away. Generally, patients will start therapy after they get their sutures out. You want to start it by the time you get your sutures out in general. Many of my patients, though, will start that first couple of days after the surgery. The next day is a little hard because you're still a little sedated and you've got big dressings on and things. So I take the dressings off. And it's also changed with arthroscopy. We take the dressings off day 1 and then are able to start the therapy. But in general, the rotator cuff rehab can be started initially. It's just that you protect it. You don't start with moving the shoulder up on that protocol. You don't start right away with active motion above the head. You protect it for a bit longer. And it has specific degrees. I have on the protocol for the rotator cuffs, start out coming to 30 degrees, then go to 90 degrees by week 4, by week 6. Here's what I want, and the same thing with the instability, each week where they should be. I would say for just about every surgery we do in the shoulder, by 6 weeks, I want to see people have all of their motion, at least passively. The last thing I want to see at 6 weeks is people not getting all their motion. That happens, unfortunately, and it'll come around. But even if someone after rotator cuff surgery at 6 weeks is kind of going like this, I don't get too concerned. That'll come along. But I want to be able to have that passive motion. That's why I want to start that right away, because otherwise it gets very frustrating for the patient to just not be able to get that motion going. What treatments do we have for patients that have problems, maybe not from a tear of a muscle or tendon, or maybe not from a labral tear or a dislocation, but from the input is gone. The electrical input into the muscle is gone, then there's a nerve injury. The nerve is not firing, and that can cause shoulder problems. The most common area that occurs in is on the suprascapular nerve, which is that nerve I showed that comes on the back of the shoulder here. And for an unknown reasons, that can just peter out on us and get compressed in some of the grooves in the back of the shoulder and lead to wasting of the shoulder musculature and problems with overhead activity. First of all, we look for a cause of it. Sometimes there can be cysts. You've seen ganglion cysts in the wrist. Cysts elsewhere in the body. It can be a fluid cyst coming from the joint that's pushing on the nerves. We look for that, usually often getting an MRI. The other is what kind of actions they're doing. In a younger patient, and the classic one is the volleyball player, repetitively coming back like this and cranking their arm back, can get impingement of that nerve and actually pinch that nerve, kind of like a pinched nerve at the wrist with carpal tunnel, through that repetitive action, and that can cause wasting of that muscle. It's a difficult problem. I do a lot of nerve releases for people like that, but nerves are different. Those are ones where after a rotator cuff surgery, I'm connecting tissue together, and then it's going to start working. It may take some time to get the strength back, but it's going to start working. Nerves, we connect together, and I'm also trained in nerve surgery where I can hook the nerve together under the microscope, but that doesn't mean the nerve is going to start working right away. Generally takes years, 2 to 5 years before the ultimate recovery of a nerve injury. Maybe we don't need to sew them together, maybe we just need to decompress them. Any of you that have carpal tunnel, you know that if you've had a carpal tunnel release, it can take months and months, sometimes a year. It just keeps getting better and better as things start to breathe easier. So it's a difficult problem, but I try to look for the source and address the source. Outside of that, of course, once again, I'm focusing on the surgical answer because that's my expertise, but therapy is very important for that. We have all these other muscles around our shoulder girdle. Can we maximize the function of all those other muscles to help compensate for that muscle that's not working properly? I have a question about frozen shoulder, and it keeps getting inflamed, and with therapy it just gets inflamed further. And I should have ended the last question because I was hoping to escape without that question. And it's such a frustrating problem both for the patient and for the physician and the therapist. And usually it's because it's in that initial stage where there's too much pain. So those are people that I think are good candidates for blocks. I'll send them over to our pain clinic, and they'll do a selective block to try to calm down some of those pain receptors in hopes of being able to tolerate the therapy. And I try to counsel people about how much time it takes. And I think a lot of this, I tell people that, you know, therapy is good, but if therapy is hurting all the time and every day you wake up and your whole energy is expended on trying to get your shoulder to move and break through that scar and you're not getting anywhere and it's just hurting you, that's going to consume your life. It's going to get you depressed, it's going to discourage your whole outlook on things, and it overcomes what you do. So I tell people, if you're in that painful stage, try to use it in a less painful arc of motion. Enjoy a hobby that you like to do things to get your life back. Focus on those things that you enjoy in life, realizing that this will get better. The frustration comes in like, it's never going to get better. I'm with this the rest of my life. That is almost unheard of. In fact, I've never heard of anyone that's had it the rest of their life. It's been reported in our literature. I've heard of it dragging on longer than a year, but generally by a year, it's going to go away. So what can I do in my mind to get my life back while I wait for this darn shoulder to get better? And so we'll try those different things, but I try to shift my patient's focus to take their life back and not have it be a wasted year. What type of material is used in the sutures in arthroscopic surgery? And that's an outstanding question because sutures in general can be dissolving suture or non-dissolving suture, which traditionally is the nylon suture. These are a synthetic nylon, and any that play tennis, it's very similar to that. It has some of the silicone sheeting around them so they slide easily and are very, very strong, stronger than any of the previous sutures that were out there. Most of these are non-absorbable sutures. They don't melt away with time. Sometimes for the people that I plicate or imbricate the capsule that I was showing, I use absorbable sutures because I want to get any knot or foreign body out of the joint. After it's scarred down, the capsule has done its job. Rotator cuff's a little bit different. I get nervous putting in an absorbable suture into the shoulder rotator cuff because I want that to be there forever and just hold as an anchor. So most people will use a non-absorbable suture for the rotator cuff repairs. All right, I want to thank you all so much for staying so late, and have a good evening.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.